Hi, this is Scott Holdsworth with the Sales Training Department. Now we'd like to move on to the Birmingham Hip Resurfacing. I'd like to introduce Blair DeWeese with the Hip Marketing Group, who's going to help us walk through the instrument trays and then do a live Sawbones demonstration for you. So let's move on to the instrument trays. The Birmingham Hip Resurfacing System uses 5 instrument trays. The first is the general instrument tray, which contains pins, jigs, sleeve cutter stops, and other instruments including guide rods and reamers for the femoral head. The next tray is femoral tray 1, which contains head neck templates, handles, and reamer handles and plane reamers. The next instrument tray is femoral instrument tray 2, which contains the cylindrical reamers and chamfer reamers for the femoral head. The fourth tray is acetabular instrument tray 1, which contains the capsulotomy scissors, mallets, and other miscellaneous instruments. And finally, the acetabular tray 2, which contains trial cups and cup introducers. And now let's move on to the Sawbones demonstration. We've laid some of the key instruments out here that we're going to use. And we have our femur already set up. If you can imagine, this would be the patient lying on the table. This is a left femur. The front of the body would be pointing this way through a posterior approach. Once they complete the capsulotomy, they're going to rotate the femur up this way, and now the surgeon has his first exposure to the femur. First step is to size the neck using the head neck templates. We're going to imagine we've templated for a size 46, so I have the size 46 template. And the surgeon will put this on the femur and see if he has a little play in both directions. A 46 looks to be a pretty decent fit. We'll also take a 50. If I look at a 50, I've got quite a bit of play. But if I hold the 50 up over the head, you can see that a size 50 would take head all the way around and would still fit on the neck. So I could use a 46 or a 50. If I go down to a 42, I put this on. This is touching the neck on both sides when I put it over. So 42 would probably be too tight to put on this femoral head. Once the surgeon has sized the femoral head, he's going to move on to the acetabulum. He'll use the size chart to determine the balance between head and cup size that he's going to use. We've templated, we've sized to use anywhere from a 46 to a 50. We don't have the 2mm instruments with us today, but now that they're approved, he could do a 46, 48, or a 50. We'll just look at his choices being a 46 or a 50, and that means he could use a 52, a 54, a 56, or a 58 cup. We're going to assume that the surgeon, when he goes to the cup, is going to decide to use a 54 cup and go under the scenario that that's what we're doing. So at this point, we'll imagine that we've gotten our exposure to the acetabulum and we've already reamed. The surgeon has decided that he's going to use a 54 cup. He'll take the 54 trial, which is actually 1mm smaller than the implant. Place the trial in the acetabulum in the position where he would imagine the cup. He can use this as a visual reference to know when his cup is all the way down. He'll take the trial out. This is a size 54 cup as it would come out of the package with the wires and the plastic pad in place. We're going to put it on the impactor. The impactor has 2 pegs which fit into the plastic pad. And then if the assistant simply holds the impactor up, as they turn this, the arms will come out and grab the wires, and fix tight onto the cup. The surgeon doesn't want to over tighten the wires, but get them just snug enough to hold the cup on. So here's your BHR impactor with the cup ready to go. The fins for stability will go inferior and slightly anterior. The surgeon will insert the cup. A typical orientation would leave about 1 to 2 rows of beads uncovered, because you do want to get the cup in a nice enclosed position to avoid edge loading. And the surgeon will take the impactor and impact the cup. At this point, I'll take the impactor off of the cup and we'll just place the cup back in about as it would be. And the surgeon at this point can lift the plastic pad with the cup in place to check his cup orientation. We're going to assume now that the 54 cup has been impacted. At this point, the surgeon would cut the wires and take off the pad, and now the cup is basically done. Since we've used a 54 cup with a 46 millimeter inner diameter, we now know that we're going to put a 46 millimeter head on the femur. So at this point, the surgeon has the cup in place and he's ready to insert the head. Today, we're going to show the short arm jig technique. This is the short arm jig. I'm going to briefly hold a template up over the femur. So this would kind of show how the surgeon would use this template to look at where he wants to put the head on the cup. This center line is the key that he's measuring. He's going to measure on the template where the center line crosses the intertrochanteric line, and he'll take a measure from the end of the lesser troch on his x-ray to this point here. And then he'll take the L-shaped ruler. We'll hold this up and can use this ruler to measure back to the point he measured on his x-ray. That will be the insertion point for the pin that will attach the short arm jig. Since we don't have a template to measure from, I'm just going to hold this pin up. This is a nice trick to do when you're doing a sawbones. I'm just going to hold this pin up and place it in the orientation where that center line would have been on the template. I want to be coming basically straight through the center of the neck, but in a slight valgus orientation. Since I know that this is where I want the center line of the implant to be, then I want to mark the point where this center line crosses the intertrochanteric line. And that's where I'll insert my pin for the short arm jig. The short arm jig uses a headed pin that fits onto this drill attachment like this. This should be set up and ready to go before the case starts. So at this point, we'll snap it onto our reamer. The short arm jig should be aligned just like this with both of these screws tight so nothing can fall out when the surgeon's placing it. The surgeon will hold the jig in position. You want to drill it? The pin is drilled through the jig, and if you twist back on the attachment and pull off, it'll come right off. At this point, the surgeon should loosen the top screw first. This will allow the center rod to come down over the head. At this point, if I hold the jig like a syringe for the rest of the time, nothing can fall out and land on the floor. Now I can loosen the stylus and align the jig. The first thing we'll check is our version angle, which we want to be right down the center of the neck. If it's not, we can use the attachment on the side to change the version angle. After we have the version angle, now we'll check our varus valgus angle. Move this slightly back. Again, we want to be basically in the center of the neck, but with a slight valgus orientation. Now we'll check our notching zone, and then move the stylus around to make sure we're clearing the neck, but taking some head all the way around. For a more detailed step-by-step of how to use the jig, you can also refer to the long arm jig technique on video. At this point, we're going to drill our pin. I'll take a long wire. And we're going to drill until it engages the lateral cortex. To take the jig off, it's easiest to loosen everything and pull the center rod out first. Then we'll take this bit again to remove the jig. And it'll slide right off. And now we'll put the center rod back on. Do a final check with the stylus. And we want to make sure our size is set on 46. Again, I like to eyeball this varus valgus angle one more time, and then do one final pass around. Again, we want to be clearing the neck, but cutting the head all the way around. Our next step will be to drill the hole for our guide rod. Before we do this, we can also place the lateral vent tube. The trocar goes in the tube so it doesn't bend. You put it in. I'm just going to take a short pin and drill a small hole in the lesser trochanter, or some surgeons might use the hole we made for the jig. Then we'll insert the tube in the hole, remove the trocar, and place a vacuum suction over the cannula. Now we'll drill over the pin to make the hole for the guide rod. Insert the guide rod. And we're ready to prepare the femur. So we've got our instruments out to prep the head. One thing we're going to do first, this is an addition to our newer instrument sets, is to use the sleeve cutter stops. This is a fairly new yet critical step in preparing the head. There's a new stylus that will measure the sleeve cutter stop. All this is a blue donut that will keep the cylindrical reamer from plunging through the head. This is a measurement device, so we want to make sure both settings are set to 46. When we put this on the head, if we line the stylus up to the medial head neck junction, this is where we want our cylindrical reamer to stop. So if we take the donuts and hold it up into this space, whichever one fits in this space will cause the barrel reamer to stop. So there are larger ones, and we want to just use the one that fills this space. So we'll put this over the guide rod. Scott will hold the template on to protect the neck. we can also put this on the handle. Use this to clean up the neck a bit. And the surgeon will also use this to measure his next cut. What we want to do is put the teeth of the reamer right where we want the implant to stop. And mark along this line. We can also measure this with our size 46 head neck template to double check. If the template is placed where the implant will stop, the 0 mark should match the line. And next we'll use the planer reamer to cut that down to this line. And finally, the chamfer reamer will just come down and bottom out. And finally, we use the head neck template one more time to check the cut and mark where the implant should stop. This is the same dimension as the inside of the implant, so if this will not spin around, the implant won't go all the way down. When we make this mark, this represents where the bottom of the implant will be. So now we know if the implant comes down to this line, then it's all the way down on the head. We'll take the Wroblewski drill and make a few cement holes around the chamfer cut. The slap hammer will remove the guide rod. And our final step is to take the finishing reamer to finish out the hole for the implant stem. Now you would take the head, fill it up with cement until about the chamfer line, turn it around so the cement coats the edges of the implant, place it on, and lightly tap the head until we reach the mark. The vit tube is left in until the head is implanted to relieve pressure and aid cement interdigitation. And that concludes our Sawbones demonstration of the Birmingham Hip Resurfacing System.